So let's understand together the pathophysiology of cardiac tamponade, and let's go back to the anatomy of the pericardium, which is composed of two layers, as you know, the inner visceral layer and the outer fibrous layer. This is the visceral layer and this is the outer fibrous layer. And the space between them, it's not empty, it is actually filled with fluids, but the normal amount of fluids in this intrapericardial space is less than 50 ml. And the pericardial effusion is defined when there is presence of a pericardial, intrapericardial fluid more than 50 ml, more than 50 ml. This is the definition as we discussed earlier in the lecture of pericardial effusion and its causes and sequelae and treatment. It's discussed in another lecture. It's more than 50 ml. So what's cardiac tamponade actually? Cardiac tamponade, first of all, it is defined as an impaired ventricular diastolic filling. Diastolic filling is impaired by this increase in the intrapericardial pressure from the fluid accumulation. Actually, the cardiac tamponade, it results either it is mostly from rapid collection of the fluid. The rapid collection of the fluids, you know, the pericardium, those two layers, or those two layers, especially the outer fibrous layer, it is a stretchy layer and it can accommodate with stretches. So when there is slow accumulation of fluid, it stretches and it can accommodate large amount of fluids. But when there is rapid accumulation of fluid, it has no time to stretch this layer, it has no time to stretch, and the tamponade physiology starts to appear. What happens exactly? This rapid accumulation of fluid, as you can notice here, this rapid accumulation of fluids, that will compress, it will increase the intrapericardial pressure. This intrapericardial pressure, it will be reflected on the heart. But which cycles of the heart are affected? During systole, the heart pumps, the heart contracts, the pressure inside the ventricle here increases during systole, which is normally. So systole is not affected much with this rapid accumulation and this with high intrapericardial pressure. But the diastole, when the ventricles are filling, there will be high pressure from outside the ventricles, from the intrapericardial, compressing the heart during diastole, thus limiting, as you can see here, limiting the filling of the ventricle. So there will be limiting and impaired ventricular diastolic filling caused by this high intrapericardial pressure. And it's not only this matter. This pressure from this fluid or intrapericardial fluid and causing this pressure, it compresses all the heart chambers during diastole, the atria and the ventricles. So during diastole, there will be equalization of all cardiac chambers pressure. So the almost very close to each other, within less than 4 millimeter mercury, the difference is only. So the left atrial pressure will equal during diastole will equal the left ventricle diastolic pressure, which will equal the right atrial pressure, as we will see, and also the right ventricle diastolic pressure. So all this pressure will be equalized during diastole, and this is very important to understand the pathophysiology. So I want you to concentrate with me. Okay, this is a real example. This is a real example of the pericardial fluid. This is the heart. This is the left ventricle. This is the right ventricle. This is the left atrium. See the space here? This is the fibrous pericardium. It is shiny. This is the inner layer of the pericardium. Okay, so what's the space between them? This is the intrapericardial space, and it is filled with fluid. See the example on the left? Okay, this is the heart See the large amount of fluids, and the heart is swinging within its pericardial cavity. And also notice that now during systole, the pressure inside the ventricles, they increase, but during diastole, there will be limitation of this filling from the high pressure inside the ventricle. So as you can notice, we call this the collapse. This is called the collapse. When you read what is collapse, left atrial collapse or right ventricle collapse or left ventricle collapse, this is very important for you to understand that this is the collapse during diastole from the high pressure. You can also notice here the collapse that on the left atrium from the high pressure. And actually, when the collapse reaches the left atrium here, this is very specific sign that the patient is starting to have real tamponading, and he may go into complete tamponade. What happens? Let's go back here. The ventricles, high pressure in the ventricles, causing limitation of the ventricular filling. So what would you expect for the ejection fraction as long as the ventricle filling is impaired? The ejection fraction and the cardiac output and the outward flow from the heart will all decrease, and this will cause an element during tamponade, an element of hypotension. And the response from the body of this hypotension, he will go a tachycardia, he will develop tachycardia with hypotension. What we will find on an ECG, this is also very classical to see an electrical alternance. What is electrical alternance? Electrical alternance means here there is low voltage wave and then a normal voltage. Low voltage, then a normal voltage. This is called electrical alternance, which is different. You can see this with large effusions and tamponades. Large effusion even without tamponades. Okay, so this indicates a large effusion. But don't mix it electrical alternance with pulsus alternance. Pulsus alternance is something different that we find in cases of severe and advanced heart failure conditions. Okay, let's continue. The pressure inside the intraprecardial pressure is high, and it's compressing the ventricles, leading to impaired filling of the ventricles and higher diastolic pressure inside the ventricles and the atria. So when the pressure here inside the right ventricle, this is the right ventricle as you know, and this is the left ventricle. This is the when the pressure here equals the pressure here, the septum, this is the interventricular septum. What will happen during respiratory variation? As we discussed earlier, that when a normal healthy person takes a deep breath, this deep breath will create a negative intrathoracic pressure, intrapleural pressure, intrapericardial pressure, and this negative pressure, it will try to suck the blood out from the heart, from the pulmonary veins back to the lungs, and from the pulmonary arteries also back to the lungs. So I am increasing the flow from the superior and inferior vena cava, and I'm decreasing the flow here, decreasing the blood volume in the left ventricle, and this will cause a shift of this interventricular septum towards the left ventricle during inspiration, further decreasing the volume inside the left ventricle, and we call this the ventricular interdependence. We call this ventricular interdependence, and this is also classical to see in conditions of constrictive pericarditis. But the most important in cardiac tamponade is that I am limiting the volume of blood further in the left ventricle during inspiration. So what will happen to the blood pressure, systolic blood pressure during inspiration? There will be further drop of blood pressure during inspiration, during tamponading, and this is what we call when it drops by levels more than 15 millimeter mercury. This is what we call the pulsus paradoxus. This is what we call the pulsus paradoxus, is that there is an exaggerated drop of blood pressure during inspiration in conditions of tamponading. This is an example also to show you the normal diastolic pressures in the heart chambers. It is lower in the right, higher in the left from 3 to 12 in the left heart, but when large effusions and tamponade physiology happens, the diastolic pressures becomes very elevated and almost equal, within only 4 millimeter mercury the difference, so they are almost equal. How do we treat? The first line of treatment in this condition is emergency pericardiocentesis. Whenever you find a tamponade physiology, this is the first line, and then we should decide whether this patient is going to go for surgery or not, when to perform the surgery after this pericardiocentesis. If the patient has recurrence, it is a purulent effusion, loculated effusion, or urgent bleeding into the pericardium, as in cases of during complication of stentings or heart surgeries. And it is the preferred method is to go for pericardiocentesis. Whatever it is, you must save your patient.